Okay, this is Dr. Khan. Sorry about that. I do not know exactly what happened. And so I'm going to go ahead and get started. I see that everyone is back on again. We will give us a few more minutes for everyone to get back on. Okay, wonderful. So I have gotten feedback from my patients and also from my prospective listeners that we're good. So I just want to go ahead and get started. Welcome, everyone. Hopefully, I can answer some more questions to the best of my ability. I just want everyone to stay nice and protected. The take home message for everyone today who's listening is you have to keep the distance and you have to stay indoors. That's absolute. Unless you have to make that trip, maybe that one time out of the 2 weeks, early in the morning. That's usually the best where patients have not, or these potential customers have not touched the groceries. Because remember, this is how it spreads. And I was mentioning earlier, if you were to lock yourself in a cabin up in Traverse City, for example, for 3 months or 6 months, guess what? You would not get the COVID-19. And unless you go out and go to the grocery store, mingle, the worst place, believe it or not, is the hospital. If you want to play Russian roulette, go outside. And I will tell you, it is very serious, especially for the junior folks, the younger people, to understand that you're not basically proof or you're not going to be a victim of this virus because as we see, especially in the US, we have a lot of younger patients who have gotten victims of this virus. And so we have to do our due diligence. I tell each and every single one, there is a big reason why I shut down my practice, because I did not want to give any of my prospective patients the virus or neither get it myself. And this is prevention is key, is staying away. I would recommend that you absolutely stay indoors. This is the ultimate proof and way that you are not going to get it. Otherwise, it's only inevitable if you go to the store that one time, that will be the reason why you would be getting it. Going to, for example, to fill up at a gas station or drive through to a Starbucks to get coffee, that person is the perfect person to transmit the virus to you, and you will inevitably get it before you even realize. Now, many of us will weather through and will have some asymptomatic type symptoms. Maybe we may not even feel it, but I will tell you it will certainly affect some of us who potentially will become victim to it, especially the younger folks. And so the best way and the only way to avoid this problem and to propagate is to stay indoors and absolutely avoid going out and making that trip maybe that one time in 2 weeks just to get your groceries so that you potentially are not contaminated, because it inevitably is going to happen. The vast majority, 50 to 70%, is what, as you will hear, of the population will get it. Anyways, having said that, let me go ahead and I'm going to scroll down and see the questions, and I will answer as we move along. I will try to answer as many of these as possible and as I move down so that everyone can benefit. The first question that I'm seeing is, I have 38-year-old silicone down corning implants, both ruptured. My left implant has a small amount of extracapsular silicone that is noted at the 12 o'clock. Now, this is clearly, as you can imagine, if the implants are intact and contained, they themselves cause problems in itself. Now, if you can imagine, if there is an extracapsular rupture and there is extravasation of the silicone outside of this compartment, if you will, and there is active bleed, you can only imagine the inflammation that the body is going to only go through. We see the drastic effects of just saline implants when they're intact, not even ruptured, how detrimental of an effect it can cause. So you can only imagine if you have silicone that has literally bled out and it's resting against the muscle or rest of the other soft tissues, how negative of an impact it's going to cause, and let alone the pain and all the inflammation, where the body's going to try to wall and mask it. But, in order to make a capsule, in order to wall it, it takes time. So the bottom line here is you have to, you likely have had an MRI in order to show the rupture. And then, as you will see, even in the many ruptured cases, it depends on how the body has protected and walled it off. As you see in many of my videos, the dissection needs to be done such that you incorporate more of that inflammatory tissue around, so that there is no spillage within the chest cavity, so that there is no eventual spread. Now, as you can prepare for this, sometimes it's inevitable, unavoidable, that the silica will be in the chest. And if that's the case, you will likely end up with drains that will need to be cautiously monitored post-operatively, such that the residual inflammatory burden is toned down after a period of time, which may be a week or 2 or 3. And then when the time is right, the drains will need to come out such that the body itself will then heal, and it will take a period of time. Now, there is this one, if you are following my Facebook actively, you will see almost 3 weeks ago, I posted this one paper out of the Netherlands where they actually did an autopsy on a lady who was very nice and bold enough and generous enough, and God bless her soul. After she died, she knew that she had ruptured implants, and she donated her body, where the researchers out of the Netherlands actually dissected and looked at her soft tissues across the body, and they concluded that there was, in this lady who had ruptured silicone, active extravasation and spread of the silicone to the many different soft tissues of the body. Now, this needs to be further studied, and there needs to be a lot more research that needs to be done. But the bottom line and the goal here is, as you will see, the whole purpose and the gist of this surgery is to do an end block such that there is no spillage. And in a well-trained surgeon, and with luck and determination, and going in with the thought that you're going to do this end block, you will see end block can be done, and this will be the best chance of containment of the silicone, such that there is no spillage within the chest cavity. And so this is basically the nature and level of the surgery that needs to be provided. Now, I will tell you, there are many surgeons. Now, when I was in training, there were many surgeons who would just go in knowing that these were ruptured implants. They would make the cut directly into, and then the silica would pour out not only within, around the soft tissue, but also on the skin and the chest. And inevitably, the silicone, the slime, if you will, would be all over the inner part of the chest and everywhere on the instruments, and the surgeon would normally just wash it off and maybe remove that capsule that was adherent or that was sticking out, but not necessarily removing the capsule. That's by far one of the worst things that can be done, because the entire surgery very meticulously needs to be removed. As you see in one of the last videos that I posted, the right implant plus the capsule is one nice round sphere, if you will. The one on the left is the shape of a heart, and you can only imagine that took me 3 times as much to dissect on the left side than I did on the right, because all of this was ruptured within. But guess what? It was all removed and blocked as one system. The patient left to home without any drains. The patient has been discharged without any problems. This was a lady who had 32-year-old implants, silicone ruptured, the old McGann, and almost all of these older generation implants are almost always ruptured, and we all know this because of the length of time. The more the implants are in the body, the higher the chance that the implant, especially the silicone or the saline, is going to leak, and the wall is going to rupture, because we know they're not meant to be there forever, period. Especially the older generation, older technology, they tend to break down easily. Not that the newer ones are any safer, but that's a much different technology. Hopefully that answers the question. What about going outside, as in walking around the block? Now, going around the block, absolutely very safe, because you're keeping your 6 to 10 feet distance, playing in the backyard, going on a hike, going in a car. I have to say that's very important. Just driving in your car, just to go out, see the sunlight, that really is important for normal mind, especially for the kids to go about. They should not only they should not be watching like hours and hours of TV. So it's very much safe to be outside, keeping the distance, going for a run. Very absolutely safe, and definitely very much encouraged. And you know, there are so many, especially with the kids. I have kids I was out with them all day, but again, being very smart about, they never went into any store. We were outside just so that they can see, and it stimulates the mind and eyes, just to see the abouts. And so it's mentally very important for them to be outside rather than being locked in. It can get certainly very depressing, but absolutely very safe when they do come back. They have not interacted with anyone, they have not touched anything, and it's as safe as being outside, because the virus is not going to be in the wind, if you will, unless you are in a very close, small apartment building, and where you have to go through the elevator. That in itself becomes a mode or a medium of transfer, because again, it's a contained environment. As you will see, this is a virus, and it is very persistent. Absolutely go out for a walk, get the sunshine as it gets warmer. Absolutely, by all means, go for a bike ride, things like that. Go for a hike. You're going to be all very much safe. So in the last month, my arms feel like they're going to fall off. Now, it's hard to tell. Sometimes, it depends. If someone has, my arms feel like they won't fall off at the shoulder, is this related? Now, if you look at the mass and the volume of the implant itself sitting on the chest, the trapezium and the back, the neck, the shoulder, the deltoid, all these muscles, they have to carry a weight. If you can imagine, I did an explant on a lady, 800 cc's of silicone that was resting on her right, and 800 on the left. This is the weight she's carrying around. You can only imagine the muscular relaxation that she had, that she did not have to carry that around on her back. And the point I'm trying to make here is, we do not know, I do not know, especially case by case. Remember, almost every time you walk into a doctor's, they attribute this to fibromyalgia, rheumatological symptoms, connective tissue disorders, joint ache, neck, back pain, everything. My point is, this might be truly related to the implant. Unable to say. I had another patient that came to me. She had a rotator cuff tear, because when I examined her, it was very unusual, and it was only on the right side. She was also elderly, and when I did ask her, she did state that she did have a fall. So the point is, the exam needs to happen, but I say to everyone, there is no guarantee till the surgery is done, and till you post-operatively state, like many of my patients have, that I have had resolution of my neck and back pain. Now, the other thing I want to mention is, it's a well-known phenomenon of breast implant illness that it does affect the connective tissue slash joint slash rheumatological problems that it presents with. Hence, the waist bag diagnosis that almost a good number of my patients get by their primary, that you've got some variant of fibromyalgia. There are patients of mine that I have operated on who have actively sought chiropractors. They have had injections in their neck and back for so many years, and for only temporary relief, but the relief that they ultimately got was when they explanted right. So the point here is, and I told them, do not get another injection till you at least get the implants out, because if you see, and I say to my patients, don't listen to me, listen to all my other patients who have had their implants removed and who have sought. If you look at the patient testimonials in the last 3 or 5 patients, you will see each one of them, they went to the chiropractor, they went to their pain specialist, they were on these medications, and lo and behold, as soon as the explant, when it was done right, they sought excellent relief in their signs and symptoms. So I would, at least the shoulder pain that you're mentioning is certainly relatively common. Even ladies, teenagers, for example, that come in with large breasts and they have had no implants, they complain of upper neck pain and shoulder pain. This is because of the weight that they're carrying on their shoulders, the trapezium deltoid muscles that are on overdrive, and so that in itself is an indication to proceed, especially with the large breasts, to get a breast reduction, for example. I have had silicone for 5 years now, 20 more cysts, major heart issues. So this is a question I was asked earlier. Now, the first thing is, you have cysts, and I'm glad that you have gone through the process of getting each one of these kind of looked at, because one of these potentially may be, and I'm not trying to scare, this is true for any person, any lady, and even men, believe it or not, men also do get breast cancer, but we have to make sure that we're potentially not missing something that might be malignancy. And it's very common, especially in the ladies in their 20s and 30s, to get cysts which are cyclical in nature depending on the monthly cycle. So they just need to have done their due diligence as far as following up a primary care / breast surgeon, just to make sure that these are something that are benign, and they just need to be usually followed with mammograms and or ultrasounds, maybe biopsies, depending if they show any sign symptoms. Now, the question I have here is, I'm looking at this one question. I have silicone for 5 years now, 20 more cysts, major heart issues. I believe they're leaking because of my illnesses. Now, I say to you, and I use the word I believe, we want to know as a fact. Now, the MRI is the best and the gold standard. I would recommend that you get a MRI without contrast to rule out any rupture, because now that is not an absolute test. The absolute test is when the surgery is done and the implant silicone is removed. That only will you say definitively they are not ruptured. But at least with good certainty, I would say maybe 99% certainty, because remember, the MRIs have been proven wrong in the past. What I would suggest is getting an MRI without contrast that will help dictate and truly answer if there is a rupture. Now, there was another MRI report that was posted on my Facebook. This was almost 10 days ago, and you will see the MRI itself very clearly states there is extracapsular rupture, there is intracapsular rupture, and the silicone is seeing extravasating towards the muscle, which is the dependent part of the chest. That helps me, the surgeon, and also the patient understand, if they're coming from out of state, that if they do have a ruptured implant, that they will most likely, given the inflammation, end up with a drain. Now, if the surgery is done en bloc and there is no spillage within the chest, and if I determined that there is no need for a drain, I will absolutely not put the drain in. If I feel that there is an indication or the thought that there might be a need for a drain or the patient may benefit, I will always put one in, because I can always remove the drain. Almost always, I will tell you, 95% of my patients do not require a drain, and they have done very happily and very wisely, because the drain itself comes when it's a whole series of problems. But the drain, when it's required, it is the best friend. And if it's not required, then it is unnecessary, and it puts the patient at risk. So going back to, I would recommend getting an MRI, because I don't want to say you feel or you believe, because we need concrete hard proof. They're leaking because of my illnesses. Now, you could have a saline implant not ruptured, intact, and still have those sign symptoms that many ladies have with silicone. So what I'm trying to say is you truly could be ruptured. The exam sometimes is impossible to determine if you're ruptured or not, if one side is soft, because you could have a capsular contracture on one, and the other side being soft might throw you off and say that this is ruptured, that's why it's soft. And that you are 105 now and constantly sick from the implants, and now you're trying to find a doctor in Houston. Now, I remember looking at your last post that you mentioned, and it was a very long post that you have had multiple cardiac issues. Now, remember, this surgery that I do, we need to, and I get a cardiac clearance / a medical clearance almost 100% of my patients, because I don't like surprises. There are many young, healthy patients in their mid-30s who have had strokes, cardiac issues, for example. And so I just want to make sure that when I do operate, even on these young, nice ladies in their mid-30s or 40s, that we have done our due diligence, again, getting an EKG and getting a clearance from their doc. So what I would recommend is, and I know reading, Lisa, if I may mention, that you have had multiple cardiac issues. So I would definitely recommend getting a cardiac clearance in your case. I would definitely do your case at the hospital. God forbid there's an issue, that we're going to be right there, and we will have the right team, and we won't have to be doing much, versus doing it at a surgery center, even as a surgery center at my place, because of your history. Because again, we need to be prepared, we need to have done our homework, and we need to be taking zero chances, so that everything has been worked up. So what I would recommend is getting, again, in summary, specifically for you, an MRI without contrast, and then getting a cardiac clearance. And then, see, one thing that bothers me is the fact that, I talked to a friend of mine in California, his very nice friend, and I asked him, do you believe in breast implant illness? And you know what he said? It depends. And that is, a honest answer from him. But you can only imagine, and he's a very nice, honest, sincere friend of mine. He truly does not believe in breast implant illness. Now, I will tell you, no matter what he does, when he's going to the operating room, if he is not a believer in BII, I will assure you with confidence, and he said it himself, I'm not truly a believer in removing the capsules. And he tells his patients clearly, and he tries to tell each one of them, well, if I can easily, I will go ahead and remove it. And I'll tell you, for me, as a board certified plastic surgeon who explants exclusively and does not augment, that is not good enough. I want 100% confidence in my surgeon that is going to go out of his or her way and remove the capsule with sincerity, because that is the cure. That is the relief that you're looking for. I don't want you to be like that very nice, smart patient who went to a very nice, reputable, board-certified surgeon who I do not know, but I personally looked up because this was part of her phone consultation. This was a very reputable board-certified surgeon who does augment a whole lot more than the explant, and who is now explanting as well. But this is a patient, from what the patient told me, was basically the surgeon who she chose because of his credentials. And now she's going to be eventually in June, if everything stays well, she will be making the trip from Arizona to come in and to see me, and I will operate on her when she has had her explantation done. And my job and role is going to be going through the same inframemory incisions like I always do, and to check directly on top of the chest wall to confirm with absolute certainty that her implants plus the capsule are removed in total 100%. Why do I say this? Because I have read the operative report with the patient that states that she had the capsules removed in its entirety, and she had the end block procedure done. Now, I will say this, if there is any capsule remaining behind, that in itself is proof that the surgery was not done right. Now, what were the red flags? I looked at the operative note, I interviewed the patient, and I asked her of her sign symptoms. I went to the criteria that I always bring up with my patients. Her surgery was an hour and a half. I will tell you, just to close the incisions, for me, doing them right takes me almost half an hour, 40 minutes between the two sides. You cannot do an end block in an hour and a half period. So that was a red flag. And I said, I question the validity of the operative report. And I say this very openly. If I cannot help someone to basically doing the right surgery, I refuse. For example, there was a forearm / involvement, a radius fracture. Absolutely, I told the patient, I cannot offer you that relief. I'm not trained. This is not my area of specialty. 2 days ago, this past Friday, I was called for 2 emergency hand cases. One was a near amputation of the finger. The second was a grinder injury to the hand, specifically the middle finger. Given the COVID-19 era, this being an emergency, I said, I'm going to step up to it. I have a responsibility, just my colleagues do. I'm going to go and see these patients, and I'm going to provide the care, because if that grinder injury goes down to the bone and the bone gets infected, this patient potentially could lose his finger. And this gentleman was 59 and he had other comorbidities. The other gentleman was in his 30s. This is the near amputation, and I had to operate on him. And the point I'm trying to make here is, when you commit to someone, you're going to offer them because you have the training and you have the expertise. This one surgeon who offered the care and expertise to this very nice lady, and she is very well read, well-rounded, and she understands the system of explant end block and what it means to do the end block right. She's going to, and I told her, listen, you're still having the tinnitus, you're still having the brain fog, you're still having the same joint symptoms as if you had no explant surgery done. And she said, that's absolutely right. And I said, for me, and I told the patient this directly, the 1.5 hours is a big red flag, and I question the validity of this surgery. I question the resolution of your sign symptoms given and how what you presented. The only ultimate way, if we get an MRI, I cannot determine if the capsule is there or not. And as you will see, whenever I take pictures of the implants, I tell my patients, more importantly, you have to take pictures of the chest wall so you can see that there is no capsule remaining. And that is the ultimate and only proof. So I say to you, when you go seek your doctor out, you have done your homework. How long is the incision going to be? There's another doc here who does in Michigan, who does her end block and a lift in 2.5 hours. 3 hours is how long she boards the patient for. And I'll tell you, the patients know better now, because I will tell you, if I could, the 3 explants I did on a Tuesday, 3 on a Wednesday, and 3 on a Thursday, for example, I could have consolidated them in 2 days easily. If I was going to run through, the bottom line here is I can only do 300 or so of these a year, plus the many other cases that I do that are not explant based. The point I'm trying to make is you have to do your due diligence, your homework. From ultimately, there's a lot of information that I get and I know from the many patients that I talk to across the country, across the world. I've had consultations from from Japan, and the ladies have come out, and if across the states, for example, from the Netherlands, and the other countries in Europe, South America, the emails that I get. The bottom line here is, each one of those criteria that I posted is an important test or a check mark for you. And number 5 is probably the most important, where you have a reputation of the surgeon who knows, who does these right, and who lives up to his word that he's going to do it, because that's the cure. Not, I believe in breast implant illness, and the next thing you know, he's done 6 augmentations on a day, and he's trying to get another subset of patients who he can explant from. And I say this to you, this is your homework that you have to do. This is your confidence. This is where you know with certainty that you have put your heart and soul and trust in the surgeon. And I say this to you, if I were to have a family member, for example, get an explant, I would go to Dr. Chun in a heartbeat in Los Angeles, the suburbs of Los Angeles, or I would send someone to Dr. Fang. These are the only 2 that I would say with confidence that I can trust. I know of no one in Dallas. I know of no one in Houston personally who I would potentially be able to, because if you can find someone, by all means. I just did another lady almost 8 weeks ago, and she came from Texas, and from the Corpus Christi area, and God bless her soul. She drove all that distance, and she was not sure as to when, and given her circumstances. The point I'm trying to make here is, you have to have that confidence in your surgeon so that you feel comfortable in making the right decision, because you don't want to be like that Arizona lady who's going to have to undergo the second surgery just to confirm that the surgery was done right. Now, muscle weakness, absolutely. Fatigue, brain fog, this whole not wanting to get out of bed. I have a questionnaire, my practice, if you email us, Jennifer can send you this out, where we check all these boxes. Literally every organ system of the body is affected, from, look at the hair follicles, the hair falling off, headache, brain fog, dementia, eye problems, skin, nasal/sinus problems, teeth, infections of the teeth, for example, name it, thyroid issues, neck, back pain, shoulder, chest, lung, chest pain, shortness of breath, rheumatological problems, joint, and I'm just going head down, and literally every organ system of the body is affected, because this is the inflammatory/hyper intense immune response that the body is mounting in order to fight this foreign body. And that's why when you see the patients, their resolution of sign symptoms pretty much improved in literally every aspect of the body. And this is no exaggeration. I say to you, and I tell all my patients and anyone who thinks of this to be a hoax type of a surgery, they don't listen to me. Listen to all the ladies, and listen to the 90s and 80s, where, remember, the implants were banned, and these were the same set of problems that we're reliving again. Look at the autopsy report. Look at the big MD Anderson study that I posted. Yes, it has its own it's a study of studies, but guess what? It is the largest study ever since 2007, when the implants were reintroduced, where they looked at the implants and determined that there are still a series of problems where you have the Sjogren's rates, the number of stillbirths, for example, the number of rheumatological issues, the same connective tissue disorders that the patients are experiencing. And let alone look at all the movement that's occurring across not only the US but the world, where the implants are now associated with cancer, and they continue to harm and cause misery to all these patients. So in regards to the post-op appointments 2 and 3, will those be done through text? Yes. So I will tell you, each one of the patients, you have my cell phone number. Each one of you patients, for any emergencies, please reach out to me. Now, what I'm going to have you do is the pathology reports for my patients. These are all yours. If you can, go to the Providence Park, the Providence St. John system, and you log in, you will be able to download those path reports, because this is part of your My File. If you now, there is no one in my office manager, including myself and Jennifer, we are at home just because of the whole executive order, and we don't want to put anyone's life at risk, and we want to honor unconditionally the governor's request for the safety of our patients, and this is what I alluded to earlier. Now, I personally 2 days ago went and took care of those emergencies, just like my other friends who are treating COVID-19 patients and in the ICU, I took the necessary precautionary measures with my patients as well, and we kept our distance. I operated with the full precautionary measures very safely. So to answer your questions, we will mail those out to you, the text reports. I myself have looked at the pathology reports the last time I was there, and all the patients who have had their path report, this is again my responsibility, I saw that there is no malignancy, and we will get those reports to you at our earliest. And I'm going to see that if you text or if you could please email Jennifer each one of my patients who have not received the path report, because I did ask my office to scan and email all my patients the path reports, because these are your properties. Please email Jennifer or the practice, and we will certainly send those path reports out to you. And each one of the patients who has not had a follow-up post-operatively, please text me and call me, and we will have a virtual discussion very nicely and safely, just like I do with my many patients who come from out of state, and we are able to, and I'm able to carry on a very meaningful post-operative discussion. If it's not immediately, when can BI symptoms typically start to fade? Now, this is a very good question. Now, if you ask the explant specialists who have done the explants right, so this is a very important point. This is where I can say, for example, Dr. Chun, who has done his explants right, because this is what he's preaching. He's not putting in any implants, and he's doing them right. The surgery where the entire capsule plus the implant is removed the way it's supposed to be done, and pretty much what I consistently follow. The question becomes, if you ask him what percent of his patients, and if you ask me, not 100% of my patients seek the benefit and relief. I would say on estimate roughly 80, 85, 90% of my patients have sought excellent relief, where they feel like, wow, this is a difference. I've noticed this. There are some patients, especially in their 60s, that have come post-operatively in a month out, that I've had a discussion with them, and they feel like they have not benefited much or at all from the surgery. And I say to them, well, one thing is certain, we can absolutely 100% with confidence say that your capsules are gone, and that your body has this fair chance of cure, period. Now, I say to myself, why did it happen to, well, 80, 90% of my patients and not to the 10, 15, 20%? I do not know what the answer is, and this is the answer we need to look at. Is it because, as you will see, and again, what is the hard proof, the concrete evidence that I have is that report with the autopsy report, where they actually did the specimen dissection, the soft tissues, nerve tissues across the patient's bodies, that one patient who donated her body, and they concluded that the silicone was basically all over the body, maybe that silicone might still continue to be present in the rest of the body. And this is something we know because it's the hard evidence for out of that one paper, one study that they did. And God bless that patient again for having shared that information. And this is not surprising, because why do people get tingling, numbness in the fingertips or the brain fog or the eye problems? Because this is all over, traveling all over the body in the bloodstream and the immunoglobulins in the immune system. And so you can imagine that once it is deposited, it might take some time, because this is that person's body's response. As you will see, the many ladies that come, especially the younger ones, that basically in the next day or 2 or 3 or 5, they're like, wow, I'm a different person. I had this magical rebound. Some patients have had a magical rebound 3, 4, 5 months, and then later on, 6, 7 months later, they're kind of starting to kind of dwindle down. And again, I do not know what that secondary phase is, if you will, but this is something that I have noticed, and this is patients who have anecdotally told me this. From Amy, is there a way to prove that your services are essential? This is not elective. Absolutely, I will tell you 100%. Right now, wouldn't those of us with autoimmune issues have a better of surviving COVID-19? I will tell you 100%. If I could, I would operate tomorrow in a heartbeat, and I would do that in a heartbeat, no questions asked. I don't want to necessarily infect that 40-year-old lady and potentially have her be admitted to the hospital on a vent with COVID-19, be it me, be it my anesthesia staff, be it my nurse, be it my patient's driver, for example, who may potentially inherit this. So for that reason, I will tell you, I'm willing, I want the governor to knock on my door and tell me that what I'm doing is elective cosmetic surgery, because she will be proven wrong if she just listens to this Facebook feed, or she listens to just a fraction of my patients who say how well they have rebounded. So this is, and I'm not in any way, shape, or form challenging anyone. I just say this is absolutely non-cosmetic, and this is absolutely just like that finger amputation, just like that one patient who I got a call from Friday afternoon who was suicidal because of the implants, and lo and behold, that was indeed a call that I took, and I communicated with that patient, and I told her and I offered her the relief I did on a Friday afternoon. And this is one of the patients I've never talked to, never interacted with. She was in a totally different state, but one of the other Facebook committee members basically got me on the line and said, if you can talk to her, maybe that might be the hope that will prevent her. In the meantime, the police did actually come to her house, and they were able to take her for psychiatric assessment and evaluation. And I will tell you, we know this for a fact, and this is no exaggeration. The ladies themselves, and it has nothing to do with me, who have had suicidal ideations, who have had implants, and once their implants were removed, all of these thoughts, suicidal ideations, anxieties, all of these were improved. And I will tell you, this is not cosmetic. This is 100% non-cosmetic. So as soon as I find, and this is what I tell each and every single one of my patients, when I do come back, I'm going to come back and I'm going to, if you will, start. And the ladies who have bought time and committed, my honor, my integrity to them, I'm going to have, and I own the operating room. I run this. For me, I will do some weekends. I will close some of the clinic days. I will stop doing some of these elective cancer cases or foot reconstructions or face reconstructions that I normally do. And I will solely, wholeheartedly commit my patients, especially the ones who were canceled, so that as soon as that availability becomes, I will absolutely jump on this, and we will go full blast, full swing with my team, so that we can offer them the relief. I do not want to go tomorrow, because I fear that my nurse, like I was saying, or my patient or myself would potentially get the COVID-19. And I'll tell you, it is nothing that we have seen so far. It is going to get pretty dirty, and the number of deaths are only going to climb. So that's why I say keep your distance and stay at home. Absolutely, you should not be going out. But the way I told you, going out in your car alone, independently, so that we can do this effectively. Are you canceling all surgeries till after April 30th? No, I will tell you, I am playing it day by day, literally, so that as I continue to, I will tell you, if this was not as contagious and it was not going to be as threatening, especially to my potential patients, some of my patients are on immunomodulators, for example. They've got rheumatoid arthritis, so they're on immunosuppression. So I don't want to risk their life, for example, and they're potential suspects for this virus. As soon as the opportunity arises where I feel that I can operate safely and I can go out, I will absolutely open the doors even before the 30th or the 23rd or the 13th deadline that the governor has set up, because this is not what I would consider emergent surgery. Now, there are some patients who are, well, I have some mild symptoms and they only checked maybe 10-20% of those boxes on my questionnaire. Those patients, I would say, please hold off. We will give the first set of surgery dates to those patients, and I will tell you, I will move fast, meaning 3 a day, and I will catch up, and I will, I'm used to working 120 hours a week, so I will certainly catch up, and I will exhaust all of my time so that we can catch up with the patients who are hurting. So are you canceling all surgeries till after the April 30th, after this news? Unfortunately, I have to say, the president has said a lot of things that are not true. I follow what, the hospital, what the series of facts are, starting the economy after the 13th, the Easter holiday, that's like playing Russian roulette. That's absolutely a no-brainer. It's like, you're going 80 miles per hour on an icy road and you're only asking for yourself to end up in a ditch and your car flipping over. That's close to or akin to suicide, if you will. That forget everything, do it for the name of love and economy, and we'll weather it through. This is called stupidity. Sorry to be blunt. We need to be smart about the whole thing. We need to certainly, if I want the economy to be better than any other country, any other place on earth, and better to be ever. But if you're unfortunately dead, there is no purpose of a good economy. Or if you're hurting or lost someone, this is a no-brainer. We have to weather it through. It has been shown by literally the many countries like Singapore and Hong Kong. Obviously that's a part of China, but you will see the spread that occurred that was minimal because they were able to contain the virus, and now their number of casualties has been minimal. Their exhaustion of ventilators has been minimal, and now this is a war that they never really started, which they don't have to fight. Unfortunately for us, the same quarantining, the same lockdown should have happened on January 15th. Trust me, if that had happened, the economy would have been better. We would not have had these 2,300 deaths or so, and many, 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 many more to come, by the way, unfortunately, from what I hear and read, just like you are. So the point here is, for the same reason, I have locked and closed my practice. And when the time is right, it will be a unanimous decision where you and I will feel content in our heart that it is safe to go outside, and the risk of going out will not hurt or burden us. I do have major memory issues as well. Absolutely. My neuro thinks I need a memory test. I will tell you, this is by far a no-brainer. Brain fog, memory issues, fatigue, all of this. If someone who is young, in their 30s and 40s, is not old age, because this is what unfortunately my patients have said. The cardiologist thinks I need a pacemaker. I will tell you how many patients have I talked to in their 30s and 40s where the cardiologist says you meet the criteria, a checkbox for a pacemaker, but the sixth sense of the cardiologist said, I'm not going to put one in because you really don't need it, despite all the logistics in the cardiologist saying that you need it. And I will tell you, can I prove? I do not know even how old you are, but I will say this with certainty. We have a lot of proof where there are a lot of inflammation, patients who have had high blood pressure, for example, or arrhythmias, and other cardiac issues. And certainly I want you to go ahead and get worked up. I mean, I'm sure you have had an echo, you have had a Holter, maybe even maybe a echo test, which certainly you would have had. And I will tell you, for someone who is young, unless there are cardiac issues that you may have genetically or predisposed, and young women do get the Wolff-Parkinson-White syndrome, absolutely. But this is a determination that your cardiologist needs to make, because this is there, the pacemaker is there as a backup, is there to protect your life in case you need it. What's the worst? And this is a determination that your cardiologist needs to make. But as you will see from my end as a board-certified plastic surgeon, there are multiple cardiac issues, arrhythmias, anxiety, whatnot else, panic disorders, for example, that may necessarily present as irregular or funny heartbeats, which may be palpitations, but that workup needs to happen completely. And then again, it is that cardiac clearance that I talked about earlier. Now, the next question, I have definitely had less shoulder and neck pain. Thank you very much for sharing that. Any idea when the last week's canceled surgeries takes place? I do not know. I will tell you as soon as we finish. My office is going to reach out to those patients whose surgeries have been canceled, depending on their out-of-state / their satisfaction, their confidence in them traveling, be it by plane or be it by distance, by car. We will work it out such that we will give you the dates. And when I do start, like I said, there's 7 days in a week, and I have 24/7 access. Within reason, I'm going to have 3 operative days with 2 clinic days, maybe 4 operative days, and we'll certainly catch up. So I will reach out to you, and we will reach out to you, and we'll get you in at our earliest. Yeah. Now when you, the next question is by Gail, should you try to sleep on your back if you have a true rupture? Now, no matter what you do, if you have a true rupture, from the time you get up in the morning, even when you're sleeping at night, you're twisting, turning, bending, doing all sorts of things like opening the car door, closing, bending down and above. No matter what you do, and you have probably done this for some time, there is nothing that you're going to do other than the posture that makes you feel comfortable. Now you may have a capsular contracture that might be causing you this discomfort. So like a good exam by a board-certified plastic surgeon. Now, I will tell you, if you are ever concerned about a potential rupture, I always say, remember, the FDA said this: if you have silicone implants, and let's say you had them inserted in 2000, just to do the numbers and the math easy, you should have gotten officially your first MRI in 2003, and then every 2 years onward. So in 2005, 7, 9, 11. So you should have had all these MRIs. So I say to you, get a MRI that basically answers the question with good certainty, 99% or so, that you're not extra or intracapsularly ruptured. That will help answer a lot of questions, because then it might be, and it helps the surgeon plan. So if you're coming from out of state, you can plan that, you're most likely going to end up having drains if that's the case, because remember, you have a lot more inflammation if you have a ruptured implant. And you can plan on having drains, and you can certainly plan on being post-operatively next to with the surgeon. I don't send my patients back with the drains. I find it, there are some surgeons, unfortunately, who commit every single patient for 3 weeks of drains, which I find is exaggerated and not warranted. And I find that some patients have actually discharged the patients to their home state and having their boyfriends / significant others, husbands, or best friends remove the drains, or even some docs. And I find that is not professional. Only the surgeon who puts them in needs to determine with a good exam as to what the indications are to removing them. So getting the MRI, and then just making sure that there are going to be no surprises afterwards. Again, nowadays 48 doesn't mean much. 48-year-old docs that I know at the peak of their career, CEO, managers, look at the presidential candidates. They're in their mid 70s. The point I'm trying to make here is that, unless you have a significant cardiac history or other issues, getting the cardiac clearance and then getting cleared for the surgery is going to be key, so that there's going to be no surprises on the operating room table or post-operatively. Next question, can a patient whose capsule was left behind feel it? No. That is impossible to state, because the only true way to doing it is you can get an ultrasound or a mammogram, and that will help dictate basically if there was a capsule remaining behind, and that is basically you cannot feel it. That's absolutely impossible. This is just like saying that someone would feel breast cancer that's relatively thin. You cannot feel it. You can potentially only feel something that's maybe at the surface of the periphery. And remember, majority of the cases, this is below the muscle. Even once above the muscle, there's significant soft tissue, and given the flatness of it, majority of the capsules will not be palpable. Now, there are some capsules that are really thick and crystallized and rock-like you have seen in my videos. Those certainly the surgeon will remove inevitably, because that's something that's going to show up on the next mammogram, and you cannot hide from those at all. The next patient is, I'm 2 weeks post-op and healing very well. I couldn't have had a more trusting. No, thank you very much for saying that. I appreciate it. The next question is, so now, can you do an explant and a lift? Can you please go to my YouTube video and see what and why I say so? Now, there are so many ladies in their even 50s that I have done just an explant and no lift, and they have done very well. Now, there are many ladies, more than just, I've heard, like say, more than 80%, 90%, who come to me in their 30s, and I tell them, absolutely, you're not a candidate for a lift. There are patients who have actually come my way, and they said, if you don't operate on me and do a lift, I'm going somewhere else. And I say to them, I'm not going to offer something that I don't believe in. So for that reason, I'm not going to do the lift, because why should I do something if I don't believe in? And I always tell my patients, number one, the tissue in itself is inflamed, it's angry. Even if you have a non-ruptured implant, you see the engorged veins, you see how the implant pushes the breast tissue up and out and laterally, and you can see how they're tender or they're a capsular contracture. Even ladies in their 50s, as you will see them attesting to the fact that they are not, and they were happy that when they came to me, what's the single most important question I get asked every single time by every single person? Almost always. Some patients don't care, but the single most important question I get asked is, how am I going to look without a lift, and how am I going to look with just the implant and the capsule being removed? And I say, well, just for me to do the end block right, and as you see how I do it with the care and sophistication, taking my time is not of any importance. Whatever length of time it takes, I do it. If I were to add a lift, it'd probably take 3 hours or so, just 2.5, 3 hours to do the real lift, which is basically the anchor / lollipop incision, and then suturing it right such that the incisions don't show, and that you have a very nice aesthetic result. I say that is the level of lift and the end block, and almost a 7 hour surgery that I would be committing. Now, lift is a very easy and simple operation. Even putting in an implant augmentation is a very simple operation. Look, dermatologists, OBGYN, general surgeons are doing it right here in town. ENT docs who have no concept of surgery, if you ask me about the chest, who have never had any true exposure to breast surgery, ENT, ear, nose, throat, who have done just like a 6-week rotation. They do on their job training, and they start putting in implants, and like they have so many across the country. The point I'm trying to make here is the lift is very simple. Augmentation is very simple. But I say to each one of you, majority of the cases, it's not warranted. Now, there was this one patient that came. I told her, given her age, the sun exposure, her history of smoking, her genetic, her age, I told her, you're going to be not only like essentially flat chested, but you're going to have a significant droopy skin, and you are a candidate for a lift the few times that I say so. And she got the message and she said absolutely yes. And I said, yep, this is no way that you're going to be able to not do well cosmetically. And so the point I'm trying to make here is, majority of the patients, now there are a lot of factors that are involved, like the person's BMI, obesity factor. Sometimes if they're obese, they have a lot of tissue, fatty, that I can mobilize, or the way I put these sutures when I do close in the same manner. Because the way I do dissect is at the inframammary fold, I dissect down into the majority of times the subpectoral pocket, and I disturb no tissue, because my goal is to remove the implant plus the capsule as one system. I don't want to potentially affect any of the normal, healthy, viable, good tissue like the breast tissue, because I don't want to distort that anatomy. And majority of my patients are very much amazed, as you will see, that they came in thinking they would not feel happy afterwards, and they are delighted to see how their post-operative results are just 2, 3, 4, 5 weeks out. And I say, guess what? It's going to take another 3 to 6, 9, up to a year for your breast tissue, the sensory ligaments of the breast tissue, to recoil even after you have hit menopause, because I don't want to subject them to another major surgery, which is the lift at the same time, to manipulate a lot of tissue which is already inflamed. Can I do online consultation? Absolutely. I recommend this to everyone. I have done a lot of consultations. This is what I tell everyone from out of state. You know, number one, see my YouTube videos, see my Facebook. And within a few hours, you know, your downtime, you can listen to some of these lectures, some of these patient discussions I've had. I find them to be very informative, where I go back and forth with my prospective patients. You know, the one with Cheryl, the one with Alicia, for example, the one with my other patients, so that you can hear out what and how I think about it. Because I say this with confidence. If you and I were to walk into, let's say, the 10 different explant surgeons who are the specialists, you will get 10 different grades of their commitment in regards to removing the capsule and doing the surgery right and leaving the drains behind, and what percent of the patients get the drains and how they manage their patients post-op, amongst the whole psych behind the end block resection. And I say to you, the one thing that's missing is obviously the physical exam, but I will tell you, there is I can tailor the consultation to the patient, so that I can answer the questions specifically and very confidently, so I can direct the plan of action. So there are many patients, for example, I talked to, and the next thing you know, their mom had breast cancer. I said to them, listen, you need to get a genetic testing like tomorrow, because number one, if you have the BRCA gene, you're going to get a mastectomy, bilateral mastectomy. That's what I would recommend, because if you have the BRCA gene, you're set up for potential cancer. And so the right operation for you is not only the implants, but guess what? You have to remove the breast tissue. That's a no-brainer. That's what Angelina Jolie and what the system will dictate. Any cancer center will tell you if you have the BRCA gene. Now, if you have the red flags, to immediate family members, and they do like a whole assessment as to what the risk factors are. Another patient, like I talked to earlier, if she's fearful that she has a rupture and she's coming from out of state, I say get an MRI. What's the worst thing that's going to happen? There is no radiation. You were in this MRI tube for an hour, and at least we will know with confidence if you're ruptured or not, and it will allow for me, as I go into the surgery, a more pinpoint / analysis as to what her true exam is like from within. Because if the lady has a contracture, I cannot tell if this is ruptured or not till I actually go in and then see from my with my clinically and operatively that this is ruptured or not. But if I know, if the MRI was done and there is no active extravasation and the entire capsule is protected, I can say with good confidence that most likely it's not going to be ruptured as I go in clinically, and I can plan my surgery, and the patient can plan her trip. I always tell my patients, say for example, if the surgery is done Tuesday, or just to make the math easy, you come in Monday, you see me face to face, I see you, I examine you, and then this is part of true informed consent. You should never do a surgery on the same day having seen your surgeon for the first time an hour before the surgery. So you have had, and come with your well-wisher, your significant other, your best friend, your husband, your significant other, so that they can weigh in and ask any last minute questions. I normally give the script to you at that time. This is where you have had the whole time where your sixth sense, you can look at me in the eye, and vice versa for me as well. And then the following day we proceed with the surgery. And whenever you come in, especially with the airlines, you get your insurance just in case you have to cancel, that it will not be any charge on your end, and I'll be more than happy to furnish that because of clinical / you had to stay the extra 2 days. If you're driving, obviously you have a lot of freedom. The hotel, the good news is very honorable in the sense that if you committed for 7 days and you left in 5, they're not going to hold you responsible for the latter 2. Now you have to call the hotel and let them, or ask them, the policies might change or whatever program that you did basically reserve under. So online consultations, absolutely very much, you know, especially at a time like this where we can get very meaningful back and forth discussions. Now, will ultrasound show the rupture? No, the ultrasound is a poor man's way of looking at things. Now, it is good. It's patient, it's technician dependent. But guess what? If your implant is below the muscle and there is a capsular thickening, right? It's like 0.5 centimeter thick capsule. Guess what? The ultrasound is not going to bounce back and look at the part right on top of the sternal / the rib cage, because that's the depth you need to assess. Even the MRI cannot assess. Now the ultrasound is better than nothing, but I will tell you, I never look at an ultrasound report unless it shows a mass that needs to be looked at or biopsied. That's what I would call. But in order to assess for a rupture, now if someone has a rupture of a saline implant, it's like a water balloon that ruptures. It's not going to rupture halfway through. A saline implant will rupture like all or none. And so you'll tell clinically if you're ruptured or not. Now, if someone's like very heavy chested, and I've seen that happen, sometimes it's hard to even palpate the implant. In that case, the ultrasound will be useful. But vast majority of the cases, just get the MRI. That kind of seals the deal, and it is very, relatively speaking, direct in regards to, and the best and the gold standard and the best modality. Ultrasound is not but like a crude way to assess the nature of the rupture. For next question, for known extracapsular rupture, are there anything we shouldn't be doing? Now I will tell you, if you have an extracapsular rupture, we know the capsule, in this case the silicone, is pouring out of the shell and potentially the capsule. And what we want, your body in itself will tell you. Now I will tell you, no matter what I tell you, you're still going to be, and like myself, I'm going to be rolling in bed, twisting, turning, bending. You know, these are things that we have been doing. Now you will feel the pain. So this one lady came to me from Nevada. After 33 years worth of implants, she had the Dow Corning. Even Dow Corning reached out to them and said, we'll compensate and we'll pay for your surgery. She said, no, these are so good. She signed the waiver that she sent me, that she told Dow Corning, you're off the hook. This is on me now. And guess what? After 33 years, she came to me and she said, my left chest hurts. Because I asked her, why are you coming to me now? And she said it was my left chest that hurt. And the next thing you know, when I did her end block, it was a complete rupture and it was all over. It was very analogous to another lady, 82 years of age. She was driving her car on a patch of ice, skidded, and ended up in a ditch, and her chest hit the steering wheel, and she had rupture and active extravasation off, literally because of the high impact on the steering wheel and the airbags. The implants truly did rupture, and she had hematoma on her entire chest wall. You could see the bruising and, you know, the internal bleeding that occurred because of her using the blood thinner. The point I'm trying to make is, in that case, we know going in that you're going to most likely have a drain, and that entirely needs to be washed out thoroughly. We're looking at antibiotic irrigation along with multiple bouts of irrigation, so the entire silicone burden is essentially removed from the chest wall. So the other thing is knowing, now there are so many patients, as you will see, doing the end block, there is no spillage in the chest, and going in, we know there is extra capsular rupture, and I kind of answered this earlier. Dissecting more of the soft tissue around so that everything is contained. On that very last video, for example, that I put forth. So the point I'm trying to make here is this indeed truly can be done, and where there is no true extravasation that's occurring, where it's leaking, if you will, in and around, because everything was contained. And one has to go in with the thought that I'm not going to let this spill within the chest wall. Yes, so I see the next question again. If I have had my silicone implants in 5 years ago, should I already have had an MRI? So according to the FDA, 3 years out, and then you should have had your second one by now. I wasn't told that, and my plastic surgeon wants to numb me and remove them in this office. Absolutely. So one of my patients, as you will see, it's amazing to see what are the different levels and understandings that the plastic surgeons have. One of my patients, as you will see, she went to a plastic surgeon in her neighboring state, and she had a saline implant that was ruptured on the left, if I'm not mistaken, and on the right was intact. So she had intact saline implant, and the left was the one that was ruptured. Her plastic surgeon, board certified, reputable, very nice IE training, ended up after discussion with the patient, given the financial he took a needle and ended up puncturing the intact normal implant, so that deflated, and he said, well, guess what, now you're got an even chest, and this is what I can offer you for a nominal amount of money. And I will say this is not an option at all. This is where all that saline within ruptured and flew and basically traveled within the body, and this is not at all what I would call the standard of care in my mind, in my eyes. And if anything, I would call this and label this as malpractice, because you have to remove that silicone burden and the silicone shell that the lady lived with for the last 2 years till I explanted her. So you have to go in with the now I will tell you, most of the surgeons don't believe in breast implant illness. And if they don't believe in it, they're not going to offer you the surgery. And this is consistent with my criteria that I put out. Next question, is doing explant on a cancer survivor more difficult and a longer surgery? Is their infection chance greater? So this is a good question. Now, one of my patients that I did recently, she had radiation on one side. Now that in itself puts the patient way up there, because her skin now becomes leathery. Number two, majority of my cancer patients are usually in their 50s, 60s, and early 70s, from what I have noticed and anecdotally, and they're the reconstructed patients. And so I find the skin is relatively thinner. They have had a mastectomy scar right in the center. So if you ask me, that's easier surgery for two reasons for me. Because the incision's right in the center, half of the implant plus capsule is above, half is right below. So for me to make a cut and cut out that excess skin, that gives me a relatively easier chance. But sometimes going in, and these ladies, they're going to have a flat chest, absolute. They usually are, from my experience, anecdotally thinner and more in their 50s, 60s, and 70s. And I find that is usually harder than the ladies that come in their 20s, 30s, 40s, who have done it for basically cosmetic reasons. And so for that reason, I find the younger the patients, the easier. There are not many 20, 30-year-olds who have breast cancer, even though there is, a lot of women in their 40s have breast cancer. But the point being that majority of the reconstructions, every single patient is different. If a lady has a high BMI, the thickness of the skin, the subcutaneous tissue, offers me good tissue to sew against, versus another lady who's thin as a rake and who has not much of a fatty tissue, let alone skin, that I have to put together. And that skin is more susceptible to necrosis slash eschar formation and potential for dehiscence. And that's why I would say it's tricky. But at the end of the day, thank God, knock on wood, I have had neither the cosmetic or the breast cancer patients have had any issues where they have had necrosis of the skin, things of that sort. But I would tell you, if I were to be given a choice, 100 patients who are in their 20s, 30s, 40s who have implanted because of cosmetic, and the other ladies who have done because of breast cancer, I would take the first set any time of the day. I want you, so Barbara is writing, I was never told to have an MRI. When you get done, if you get a chance, just Google FDA recommendations as to when to get an MRI and how often, and you will see that. Many of the docs, unfortunately, don't talk, and there is no true part of the informed consent that comes in from this. And if you go back to my feed in my Facebook, I try to post almost on a daily basis something new that I have learned, or I can share, or a path report, or be it the COVID-19, whatever, just so that I can keep my patients informed. So, so the bottom line here is that this is well established. Now, how many of the patients follow through? How many insurance carriers deny an MRI every 2 years, especially after the 3 years that the patients have? Almost all of them, because they ask for an indication. So there is true conflict. And as you will see, you know, the American College of Surgeons stepped in, and their director, Dr. Frank Lewis, said this is obviously comical, where you would expect just to play it safe for the patient's own interest, and they didn't follow this, MRI protocol. This is what percent of the patients get an MRI every 2 years after their 3 years off, and not many, and only a fraction. And this is where, you know, sometimes if you will read, the seat belts in the car need to be changed every so much often, according to their guidelines and criteria. And who changes that? How many times are you aware that how often on a regular day, let's say last year, how many surgeons are supposed to, and how often are they supposed to change their mask on a given time per day? You will see, you will be surprised by the number, but in reality, no one follows through. The next question I have is, for implants under the muscle after explant and muscle repair, should we expect to have full use of that muscle after healing? I will tell you, the muscle gets attenuated, which means thinned out. So let me give you an example, the better way to describe. So if I'm a bodybuilder, if a patient is a bodybuilder and goes to a plastic surgeon, the plastic surgeon will inevitably put the implants above, because they don't want to compromise the muscle, because the bodybuilder's whole physical effect will be altered. A majority of the plastic surgeons, 95% of them or more, are going to put the implants below the muscle, because that's more predictable and the better standard of care, FYI. Now, the muscle is repaired, it's attenuated. And guess what? If someone has had a muscle, under the muscle reconstruction, what happens is the patient truly has not used the muscle effectively for that 10-15 year long time period, because every time they would use their muscle, guess what would happen? They would move the implant and they would feel kind of awkward or funny, like some patients have described, and they truly have not used it. Now, not only is the pec muscle involved, you have the pec minor, the deltoid, the biceps, and all these other muscles. So as you will see, when I start off, I tell my patients that usually the week 8 mark, go ahead and get like a 3-pound, 5-pound weight and just slowly start working. For the first 8 weeks, I say every time you open a drawer or lift your cell phone up, you're just kind of normalizing, so you're not spasming your pectoralis. And then, just like any bodybuilder or someone who's thin as a rake, very small build, and you have them build their muscle mass, you will see in 3 months, 6 months, you will see the same person would have developed the muscles and would have strengthened not only the pec major, but the pec minor, serratus, and all these other muscles, the latissimus and the deltoid, such that the other muscles would also get stronger, including the pec, and you would certainly 100% build on that muscle. And that's the whole purpose. And that muscle repairing not only physiologically gives you strength and manual dexterity, amongst the many other ways that you would be able to lift, but also it adds volume to the chest, which is important, because that's the volume that you don't want to be missing at a time where you need all the volume that you want. Next question. I just went to my plastic surgeon for a possible capsular contracture. He said surgeons are starting to change their minds on performing a full capsulectomy upon explant, and C and N block is only performed if he said surgeons are starting to change their minds on performing a full capsulectomy upon explant, and an end block is only performed if there is cancer involved. I was shocked. Is this true? So this is unfortunately held strong by many of the plastic surgeons. And this is the whole gist of the conversation. If you don't get anything from this Facebook Live, this is what I want you to take home. The capsule that the body itself forms around the implant has in it the impurities, the toxicities, the silica, as we all know because of these pathology reports that I have put forth. And as we know from the heart evidence by looking at it and basically shining bifringent light and saying that this is silica. Just removing the implant alone will leave that capsule behind, and that capsule will continue to mount, trigger that silica, that foreign body reaction that you will see, and the body itself will continue to fight this foreign body. The entire capsule needs to and must be removed for the body to be given a chance of this cure from this toxin, which is the silica, which the body has in it in the capsule. Once the capsule is removed, then only does the body get a fair chance of recovering and bouncing back from the breast implant illness symptoms, period. Now, there are some capsules that I myself have sent to pathology, and lo and behold, came back as no inflammation, to my surprise. And this is like the foreign body silica reaction. And I'll tell you, vast majority of the patients have this reaction, but only a very small subset. Having said that, you have to remove the entire capsule, period, because if you're not, then you're leaving that burden behind, like I said earlier, and your body is going to continue to mount that trigger. What your plastic surgeon said is continues to be held by vast majority of the plastic surgeons, and this is where I caution and warn that that is not the answer. That is the same when I was a fellow in training. This is what every one of my attendings were doing. What I'm doing is a new thought where you're giving the body a chance to bounce back because the entire burden of the silica is removed. So he is not accepting of BII, and he's not accepting of the fact that the cure is related to the removal of the capsule. And I say that is, as I practice my plastic surgery and the end block, that is something. What I find, what he is saying, number one, he's honest about it, so good for you that he was able to tell you. And number two, he's not going to remove the capsule, which I'm in total disagreement with. And hopefully as we move forward, I tell him and I tell you, look at my Facebook feeds, the pathology reports where you see the silica, foreign body reaction, macrophage reaction, multinucleated giant cell reaction, where the body is trying to fight this silica. Leaving that behind, the silica, the body will continue to mount and fight that response. And this is exactly the whole purpose of me doing it differently and what I feel in my mind the right way, because I'm not leaving anything behind, to answer it as simply as that. Now I want you to go ahead and please see my YouTube videos and my Facebook other videos that I've put forth, so that he and I can truly basically understand as to where I'm coming from, because I'm totally negating what he's saying, and I use the word totally because this is the whole difference between my practice and the practice of the many other plastic surgeons, even in Houston, even in Arizona, even that plastic surgeon who basically feel that that capsule is not the toxin and that capsule need not go. And this is where we are at difference, and that difference is the difference between you rebounding and improving versus not improving. And hopefully that helps. Implant above the muscle, 30-year-old implant. So I will tell you, this is most likely the silicone implant, and I will tell you because it's 30, most likely potentially there is an intra or an extracapsular rupture. I would recommend getting an MRI just so that we have that information, is if you will, just so that, again, you are not going to lose anything other than the fact that, nowadays if you have to pay out of pocket for an MRI, it's $350 at majority of the imaging places. And there's no radiation involved with the MRI, and there is no contrast that's given with this MRI. This is the MRI without contrast, so you lose essentially nothing but a lot of data. And I say this to all my patients, getting a explant done right and block is very analogous to a Navy SEAL mission. We need to do the homework, the going into the surgery, knowing all what we need to know so that there is no surprises, taking care of the end block right, and then coming right out of Dodge. You don't want to be in and around or having the patient on the operating room table for a minute longer, because if surgery is done for 6 hours, that has been shown, the chances of clots, the chances of infection, the chances of potential complications as a result of suturing, all of them go up or start to going up after the 6-hour mark. The bottom line is getting the MRI is smart. It helps prepare for the surgery, and it never hurts. Is muscle repair a case by case? Yes. So muscle repair is a case by case basis. Sometimes, depending on who did this reconstruction, they truly put it below the muscle. Now, a muscle of a 68-year-old lady is very different compared to another lady who's 22 because of the level of muscle that's present. The muscle in the 68 is attenuated, and it's been there for such a long time. But having said that, the muscle has to be repaired. Some of the plastic surgeons or the other non-plastic surgeons, who are the general surgeons, OBGYN, dermatologists, ENTs, who are putting it in, they're doing it under the dual plane. So half of it is below the breast, the other half is it below the muscle. And there are differences or inaccuracies not only between how it's done, but between one side and the other, because they're not truly trained. So the point I'm trying to make here is, only when I do go in, sometimes the MRI helps me, but only when I do go in, I see what exactly is the position of the implant plus the capsule, so that when I do, absolutely the muscle needs to be repaired. If it's above the muscle, there's no repair that's needed. If it's below the muscle and part of it is below the breast tissue and the other part is below the muscle, then the amount of muscular repair is not much. So what you can do is you can email my office, anyone who's interested, and we will set up a time. I will give my cell phone number or text, just so that when I do talk, I don't limit my phone consultations for 5-10 minutes, because I find I only get started in 5-10 minutes. Usually they last half an hour to 45 minutes. And again, these are true consultations. The only part that's missing is the physical exam. So what you can do is you can email my office, and Jennifer will email me, and she'll get you plugged in the system, so that I then will text you and find a time that's good for you and I, so that we can have a phone discussion where we can discuss and really start discussing about the patient herself and her symptoms, as to when she got augmented and what her signs symptoms are, where she lives, and why, and what homework she has done with her primary care doctor or her rheumatologist or cardiologist, so that we can basically be very specific about her well-being. Next question. So if I'm coming from Texas, I'm looking at 7 days of being in Michigan. Yes. So on average, if you will see 5 to 7 days, there are some patients that I tell on the day off that they're going to be going back and driving back in 5 days, just because I feel comfortable. If something has to happen, they have had 5 days to declare it. And again, I can tell a lot on the day of the surgery, how the surgery went overall. So I feel very comfortable about. Now, if I went in and both the implants are ruptured and I spent 6 hours dissecting at their drains, you can easily understand you're looking at not only 7, but on average maybe 8 days or so, or 9 days. Like I said, I don't send the patients back with their drains. So 7 days on average, I say for everyone to plan, maybe 5. On average, if you were to look at majority of my out of town patients, they're heading back at day 6, if you will. So thank you very much, Ms. Simon. You're wonderful, and I have to say you've been truly a pleasure to take care of, and God bless you for answering and helping the other ladies. My plastic surgeon explanted and left a bubble thin capsule behind. How long should I wait to know whether I fully heal? I still have waves of itchy rash, which was my primary reaction. Now, I say to you, this is for Leanne, and again, this is no HIPAA violation. This is, again, a private group, and again, the whole purpose is for each one of us to benefit, with all due respect. So I say to you, number one, what were your symptoms going in? What were your symptoms going out? What was the reason why that small patch or bubble of that capsule was left behind? Was it adherent to the chest wall? Because I will tell you, that's the entire gist of the surgery. The, the hardest part of the whole surgery is when the implants are below the muscle, the dissection is done such that the entire capsule, including the fascia of the intercostal muscle, is removed. This is how I do it. And this is the risk slash benefit ratio that I look at, where I'm actually removing the fascia of the intercostal, because that's truly the way to doing it. And you essentially have to, as you will see in the many pictures that I've put out, essentially burn that cartilage part of the rib in order to elevate that capsule off and remove the capsule off in its entirety, period. There is no other way of doing it. Some surgeons, I heard one surgeon used argon beam. That is wrong. You don't burn it off, because the top part of that burn, that coagulum is going to wash away and erode away, and the next thing you know, you have the residual capsule that's remaining behind. You cannot bovie or cauterize it because you still have that silica behind. And I tell this to all my patients. Guess what? When you get like your shot, your mumps, measles, rubella, or your hepatitis B, it's a small amount of fluid that they inject in the body itself, mounts an immune response. You could have a small capsule remaining behind, and that might be all what you need in order to continue the trigger. Now, I always like that patient. I kind of answered this question from that Arizona patient that's coming in mid-June, supposedly in mid-June, hopefully if everything remains well. But I always ask, what were your symptoms before? What are your symptoms now? Number two, how big of this area is it? I need something in centimeters. What was left behind, and most likely it was left behind on top of the rib cage. Number three, if there are no, now this is one itchy rash that was one. Now if you look at my YouTube video, there's another lady that came in with a bad itchy rash, and she had multiple other issues that were going on, and I chose to operate on her kind of emergently because I did not want her to get an infection because of that bad type of rash. And I want you to please see that video. This is from almost 8 months ago or so. Now, you need to define in your mind how and what level of commitment you have in regards to zeroing the chance that you have zero capsules, so that you give your body a true chance to recover. Where is this rash? Have you seen an allergist, immunologist? Basically you might have a rash secondary to something else. Is this something that is the only thing that's bothering you, or are there other signs, symptoms, or of that questionnaire that continue to haunt and trigger you because of that breast implant illness problem? So now comes the point on your end, how badly is it affecting you? So going back to that Arizona patient, she knew going in she wanted a complete end block. She knew her surgery was done in an hour and a half, and she knew that she has the same sign symptoms, the tinnitus, the arthritic joint pain, the same fatigue, the same sign symptoms, almost 2/3 if not more of the sign symptoms. So I said to her, what I'm going to say to you, what time has elapsed between that surgery and now? Meaning, if you just had the surgery 2 months ago, you want to wait it out and see how you're going to be in the next 6-9 months up to a year. I normally say at a year mark, your body has equilibrated, normalized, and reached that plateau. Giving it another year is not going to improve it much further. So I say to you, and this is exactly what I said to that Arizona patient, if this is how it's affecting your life, and you are bothered by it, and you have ruled out other aspects that are causing you this itchiness and this rash, I say to you, what are the risks? The risks are going under the knife again, and I say as a local plus sedation, that's still a risk, but again, very acceptable, very minimal, the same, twilight type of anesthesia. And to basically removing that, and this is exactly what I told her, removing that from the equation, so that option does not exist. And maybe it might be something else, maybe it might be a GI issue. Now this one lady that came to me, she had a rash directly on the breast tissue, and this is, her breast literally went on fire, as you will see on the YouTube video. And the bottom line is, that was the culprit. That was because post-operatively, We saw months out that she continued to have no rash, and it was a very direct cause and effect. And what's interesting is she was seen by the dermatologist, she was seen by her endocrinologist, as you will see on that YouTube video. And guess what? She had complete resolution. And I told her going in, my gut instinct is you're going to do well, because once the end block is done, you're not going to have any more rashes. Now, she did have, what's interesting is another spurts here and too, but guess what? After the 6-week mark, she had no rashes. And I will be very much, and she knew, and she was in the medical field, she knew with absolute certainty it were the implants, because as you will see when you see her video, this is like a video, just like a 3-minute presentation as to how and what her presentations were, how dramatically she improved. So in summary, I leave it up to you to decide how significantly you're affected by it, and if you want to delete this from the equation, so this is not even an option worth mentioning or discussing, i.e. so that your body is given a due chance to recover and to relieve yourself of this, what you would be a bad itchy rash, which was the same complaint that she had. Can I schedule MRI myself? No, I will tell you what I would recommend is, now I have no problems. If someone does a phone consultation with me, I have written for MRIs without contrast, because it really doesn't hurt the patient, unless the patient has a metal, then that's a contraindication for an MRI. But I normally feel comfortable writing for the MRI, because it is a consultation that I have. Now, I always tell my patients that, if you feel comfortable with me and you follow through and write for the MRI, and that, this is something absolutely you can take to your advantage, so that we can plan your post-operative course and plan for the surgery very effectively, I'll be more than happy to, which I've done for many of my patients. Now, one thing I want to mention is, I hate to make comparisons with the coronavirus and COVID-19, and maybe you ladies can share with me what your thoughts are. The coronavirus is probably the worst thing that has happened to a lot of people, especially the younger folks who have not lived through. Now, I live in the world of trauma, reconstruction, badness, as you can imagine, from burns, car accidents, cancer, and I see death and destruction every single day, even with the H1 flu. Ladies who have hit breast cancer and bounced back, and good for them. And we live in a world that if we were to thank God every single second, we'd probably not be able to thank him enough for what we have. I tell myself, I practice explant surgery, and I preach it to not only, I talk to my plastic surgery friend, my emergency room friend that I talk to now that I have more time. And many people are not wanting to even hear what is BII and the relief that there is. I say to everyone, the coronavirus is there, and I make the analogy in my mind, and I'm not even a patient. Look, everyone's talking about it. Look, breast implant illness, not everyone is talking about it, and not everyone is even sold on what is breast implant illness, let alone the plastic surgeons, the general surgeons, the rheumatologists, all these other subspecialists. And so I find this is the responsibility that not only I see a lot of nice, grateful patients, and I say, what, this is my job, this is my responsibility, and this is what I find the responsibility of. Look, how many of us are being helpful and trying to make and help the elderly with their groceries, amongst the many other things that we do and we never share. And I say what we need to do is we need to bring the same level of awareness. Because look, coronavirus, everyone knows is bad. Breast implants, everyone says is good, still, to this day. And we need to make that awareness so that we can tell, look, that other text from that other nice lady, the mom of 2 kids who texted me and she was distraught. And the many other texts that I got and said, when are you going to open up? And I said, trust me, I would operate today if I could, if I knew I was not going to get my next patient infected with the coronavirus. And so I say to each and every one, we need to make the awareness. Look, I send another text out, or with a post where this one plastic surgeon has seen now a 50% decrease in the number of augmentation consults. And the bottom line is, us by talking and sharing and discussing. Just from what we have, we will spread the word that implants are not worth it and they're only detrimental. They don't last forever. They have been recalled. They have caused cancer. There's so many patients that have had many other issues and illnesses who have unfortunately passed away, and it was the implants that was the cause of their demise. It was the cause of their social reckoning. It was the cause of their family falling apart. It was the cause of their suicidal ideation, the rheumatologic problems, back, neck, head, eyes. And imagine if I don't sleep well, on a post-call day, sometimes, you see how bad we are the next day, like we are accelerating through just so that we can not sleep behind the wheel. And imagine a lady spends 16 years of her life not able to sleep well, and the whole anxiety and the panic attacks. And the point I'm trying to make here is this is not cosmetic, and we need to talk about it, and we need to make a change. And if each one of us writes about it, I will tell you, next month it will be a better place, as far as us understanding the detrimental effects of the implants. Now I'm going to go back to the next question. I read a lot of surgeons don't believe a total end block with capsulectomy is necessary. Is this true? Yes, that is true, because not many people want to believe. This is a new understanding, a new thought process, and this is hard evidence, as you will see if you go through my Facebook posts, that the implants, the capsule that has formed around the implants has in it the impurities, that the toxicities, the silica that continues to mount. And look, who wants to leave that thick, hard silica, that entire capsule around? Now, when I was in training, I will tell you, do you know how many end blocks I did? 0. Do you know how many I did in the first 3-6 months of my practice? 0, because this is what I was taught. Now, as I went and moved forward and I removed more and more, I realized that this is the surgery where the end block 100% needs to be right, so that just like that one other lady and that lady in Arizona, we don't give it a chance for the body to potentially say, well, some of that misery was relieved, but the rest of the other symptoms continue. So we want to leave no burden behind. I have MS and have tried everything to get rid of my overactive bladder. Now, I will tell you, there are multiple sclerosis is one of those things that will seek and destroy and cause problems that you will be surprised you will not even know about. Now, I'm not a neurologist, but I've seen this, heard this. If you will just do a search on my Facebook page, you will see so many of the dramatic improvements in UTIs. This one lady came to me. She had 30 UTIs. I think I mentioned that on my last Facebook. She has to go see a urologist, make sure there's no surprising or reflux or a stone or whatever it may be, or cancer or a polyp, benign polyp. But once that is done, I will tell you, many of my patients have sought excellent relief as a result of their symptoms of, overactive bladder and, the cystitis, UTI symptoms that improve. I will tell you, the only definitive way is once you get the explant done right with no capsule remaining behind, we will know definitively as to how you're going to seek the benefits of the explant done right, and the sign symptoms, resolution of your sign symptoms. Look, if the brain fog, the anything itis like colitis, anything itis inflammation, so cystitis, uveitis, which is with the eyes, for example, arthritis, any of this improves. And the point I'm trying to make is, I'm not guaranteeing you're going to have resolution, but at least you would have had the implants. Now remember, the implants are not causing you good health. 100% the implants are only causing you harm. There is no questions asked. Number one, they're not supposed to be there forever, 7 to 10 years. And the other reason, they're obscuring in itself breast monthly exam, where this is the number one most common reason why women pick up on breast cancer, let alone with the mammogram, how it obscures a good mammogram, and many patients are afraid, or even the technologists are afraid to getting a good mammogram. I will tell you, only when you explant you feel great. And like I've said on almost all my Facebook feeds, we vote for someone, we buy a car, we buy a shoe or a watch, we have a remorse. I shouldn't have done that. I should not have gone on that vacation. It was not worth it. This is the most personable surgery that any of the ladies are going to do. And to date, not a single patient, and I say this and I challenge any one of my patients or any of the patients who have explanted, have ever regretted doing an explant. And number two, if anything, they said they would have never put in the implant, or they said they would have removed the implant sooner and they regret having waited. And I will tell you, why should a surgeon do any surgery where you have this absolute happiness from the patients who have explanted? And that alone is a reason to not do the surgery, if you ask me. The next question is, and I want, this is the beauty. Like 4 months ago, I started this Facebook thanks to my very nice patient, Alicia, and then Cheryl, who basically followed soon thereafter, my office manager, Lori, and Jennifer and Marlena. And I say, it's been a very good, and even for me, I will tell you, I probably did something wrong when I was doing the Facebook Live with the sound, but I say this to everyone. This has been a very good tool, and I want each one of us, again, with the privacy of their patients and respecting that unconditionally, that we basically make this a better experience so that we can learn off each other. I say this with absolute confidence. Almost every surgery that I have done, 100% of my patients, I've given my cell phone number to. So I want the medical advice to be coming directly from me. The experiences maybe from the patients so that they can help understand the system better. Or prospective patients, they can ask questions. And I say this to you, we're 100% open. Earlier today, one of the other patients told me one of the feeds that I put in from a Hopkins infectious disease doc, which I found was helpful. I was told by 2 of the sources that this was not reliable. I took it down because I don't want to misfeed or wrongly give information out, because this is something that I found, thought it was useful for me, and I wanted to share it with my patients on the COVID-19 and what a Johns Hopkins infectious disease doc thought of the best way to understand this illness and this virus. And because I found that it was not authentic, I took it off. I want hard evidence. I don't want to ever look back and say I gave anyone even 1 ounce of wrong information, because it is all, at the end of the day, for the benefit of each and every one of us. And if I can make a system better, I'm absolutely wanting to hear. At the end of the day, we're just trying to make this world a better place, one patient at a time. I will stand on rooftops. I have already shared with many. I want the next thing what I'm going to do is I'm going to do another Facebook Live in the next couple of weeks. I find this, since we don't have much of anything else to do. One thing I always tell each and everyone, especially for the young kids that are, our responsibilities, every minute is precious. Every moment is precious, especially with the books and studies and the schools that are off. They're 168 hours in a week. They have to be studying. And there are many people who actively study on a daily basis and are homeschooled. And if you look at the spelling bees, these are the kids that were all homeschooled. And the point I'm trying to make here is we can do as good as a job, if not better, than the schools. We need to discipline the kids in a sense that they have their homework still. They have their online classes, the reading, the math. They have to do a lot of their responsibilities, you and I, on a daily basis. I will tell you, the other day I was up till 3. I have a lot of paperwork to catch up on, a lot of discussions I have had with my other friends from out of state who are plastic surgeons, who are doing a lot of cosmetic surgery. That basically I'm trying to be as productive as I can be. Even, as we sit here, I'm going to do phone consults so that I can make this a productive time and help every patient that I can. Anything else we can do, my practice, we will certainly, in conclusion, send out the operative reports to whoever it may be, so that your insurances / your pathology reports you can look at and be content that you have gotten everything that you and I had discussed on the initial consultation. Thank you again very much. And I wish you the very best. God bless you all. Stay indoors and practice, if you will, exactly this simple concept that if you were to lock yourself in a cabin or your home apartment, you will not get it 100% because you would not have had any contact. And that alone is proof that once all of this is said and done and we're all safe, the first available chance that I get within reason, and I will go ahead and start operating, and I'm going to exclusively operate on the explant patients so I can catch up and offer my patients the relief that they very much need. Thank you again very much. Bye-bye. Take care. All the very best. Please share with your colleagues, friends, whoever it may be. This is a good time to share data and that we can stay well informed. Bye-bye. Good night, and God bless you all. Bye-bye.